Hi everyone, my name is Mariana Velasquez. I'm one of the Jackson Chief Residents for Internal Medicine, and it's my pleasure to introduce Dr. Souza, our newly appointed Assistant Professor in the Division of Endocrinology, Diabetes, and Metabolism. Her clinical interests include lipidology and metabolic bone disease. She returns to the University of Miami after completing her endocrinology fellowship at Duke University, where she trained in clinical lipidology until the renowned Professor Dr. John Guyton and conducted genomic research in osteoporosis at the National Institute of Environmental Health Sciences. She also completed Duke's signature health disparity research curriculum. As a former internal medicine resident at the University of Miami, she was recognized with the Randenstrom Nascimento Program Service Award. She earned her medical degree with honors as a national scholar at the University of West Indies and previously held a faculty position in pharmacology at St. George University. Beyond her academic and clinical achievement, she is deeply committed to healthcare equity, a passion rooted in her upbringing in Trinidad and Tobago. She has received multiple teaching and academic awards, but consider her most heroic accomplishment to be recently becoming a mother of twins. Please join me in welcoming Dr. De Souza.
Thank you so much, Marina. It's an absolute pleasure to be back here and in front of this podium. I see a lot of familiar faces and I see a lot of new ones as well. So today we're going to be doing a case vignette. I speak a little quickly, but I'm sure everyone here can follow, and we have limited time, so let's go. This is a patient that I saw in my first month of fellowship at the VA. At that time, they were still transitioning from their COVID protocols back to regular. So this patient was actually seen via telephone. His first question was, Doc, can I get a PCSK9? So we're going to be talking about the endocrinologist approach to dyslipidemia and the concept of statin intolerance. Oh, my little clicky's not working. One sec. There we go. Financial disclosures, I have nothing to declare. So upon completing this brief activity, I think that you guys should be able to select appropriate initial additional testing in patients identified to have a dyslipidemia. Also to be able to apply ASCVD risk stratification in selecting patient-appropriate targets. So not everyone has to aim for less than 100. It's a little more nuanced than that. I also want to impart on you an appreciation for the potential percentage reduction in the different parts of the lipid panel that can be conferred by different medications, and to understand what exactly is statin intolerance and to identify an appropriate therapeutic approach to patients who might experience this. So the question becomes, who owns the lipids? Most people are probably wondering, what is this endocrinologist doing coming to talk to you guys about something that seems to be owned by the cardiologist? So, we have a little feud. We invent good drugs like Jardiance, and then the cardiologists take it away from us, is how I feel. But strictly speaking, preventative cardiology does a lot of consultative lipid management. Cardiologists are fantastic clinical trialists. So a lot of the real world data that we have about the effects of these drugs come from cardiology, come from that cardiology space. Endocrinology and metabolism, as you know, we love our numbers, we love our labs. So we are mostly responsible for things that go on behind the scene, developing tools and equations for measuring lipids, lipoproteins, and elucidating the metabolic pathways. There is an association called the National Lipid Association. There was an audit of their members in 2010, and in actuality, the majority of the membership is comprised of you. Most people here are going to be general internists or internal medicine residents, so by effect, a general internist, or family medicine practitioners. A further 32% are cardiologists, 11% are endocrinologists, and 7% are some other specialties. So let's start with the patient. This was a telephone visit, no video. He comes in from his PCP with high cholesterol. He's refusing to take any medications because he has statin intolerance, and he wants to know, can I get a PCSK9? He cuts to the chase. He's 60 years old. He does have type 2 diabetes, hypertension, established coronary artery disease, which is obstructive. He had a myocardial infarction at the age of 54 that was treated with a drug-eluted stent. He has no history of peripheral arterial disease. He's a current smoker. 30-packet history, no other substance use, no alcohol use. He states that he's able to exercise. He states that his diet is low in cholesterol and that he avoids fried or fatty foods. His family history is quite significant for multiple ASCVD events. His mother, father, and brother have high cholesterol. both parents had a myocardial infarction, and getting that history, it's important to elucidate the age. The age was less than 55 for both of them. So this is premature ASCVD. He has a brother and two uncles who had aortic aneurysms, most likely AAAs, and he had multiple family members with strokes. So for him, his lipid medication history, he started statins at the age of 54 at the time of that index myocardial infarction. He has tried simvastatin, he has tried atorvastatin, he has tried rosuvastatin. He reported that each of those caused severe muscle pain within 1 week that resolved on stopping the culprit medication. He has never tried other strategies. So he has never tried alternate day dosing of statins. He had never tried a lower potency statin, such as pitavastatin or fluvastatin, and he had never tried taking coenzyme Q10 at the same time as the statins. He was placed on ezetimibe. He claimed to experience a statin-like reaction with muscle pain. This is not uncommon. I have many patients tell me this with Zetia, even though it's not a labeled side effect on the box, that they do experience that. With fenofibrate, he did experience muscle cramps as well. And with a trial of gemfibrozil, we had objective data that his LFTs became deranged. So what is he taking currently? For his diabetes, he's taking metformin and 2 insulins, aspart and degludec. We're focused more on the lipids here, so I won't get too much into the details there. For his heart disease, he's just taking lisinopril, clopidogrel, and just fish oil over the counter. He says that his most recent blood pressures are less than 140 over 90. Most recent BMI we had in the chart is quite elevated. It's 43. Ideally, when you see these patients in the lipid clinic for the first time, you'd like to do a targeted examination, looking at their peripheral and carotid pulses. In particular, it's important to check their femoral pulses, popliteal pulses, and dorsalis pedis to evaluate for any decrease in perfusion that might be keeping with peripheral arterial disease. Of course, we're going to do cardiac auscultation. We're also going to be checking for vascular bruit. So we'll be checking at the main points on either side of the umbilicus for renal artery bruits, femoral bruits, and carotid bruits. And then you can look for features that are specific to the inherited hypercholesterolemia, so tender xanthomas, eruptive xanthomas, corneal arcus, and xanthelasma. Now for his labs that we have. When he was on fenofibrate at a maximum dose of 145, as well as fish oil, a total of 2 grams daily, he had a total cholesterol of 163. Within that, the non-HDL cholesterol was 131, his HDL was 32, and his triglycerides were 310. When he was not on any lipid-lowering agents whatsoever, the point on his lab that stands out the most there is his triglyceride. It was quite elevated. Can I point? Yeah. It was quite elevated at 1,880. He reported that he had triglycerides higher than 2,000 in the past. On that assay, they did not do a direct LDL measurement. They did a calculation of the LDL from his total cholesterol. So the LDL was calculated as being 89. I don't necessarily believe that because this is a man who had premature ASCVD. He had his heart attack when he was less than 55. And it's important that we understand how the lab comes to this number. At that time, the VA was using an equation called the Friedewald equation, which we have here. I won't spell it out. The important thing to know clinically is that this method of calculating the LDL from the HDL and the and the triglycerides is only valid if a patient is fasting, first of all, and then it becomes increasingly inaccurate once the triglyceride levels are more than 200. And it becomes just altogether invalid when triglyceride levels are greater than 400. So for this man, we can assume that this LDL of 89 is being grossly underestimated. His estimated GFR was low at 55, so in keeping with about CKD3. His diabetes is perfectly controlled, his A1C is 7%. He had normal liver function tests. And then we have 2 more tests that I'm going to talk about in more detail that are pretty specific to dyslipidemia. So we have ApoB, which in his case was 124. The lab lists anything as 130 being high risk. He also had a lipoprotein little a or LP little a. His level was 40. The lab lists anything between 30 and 50 as being of intermediate risk. So what is LP little a? I got this little pictogram from some patient education materials from the ACC, and I thought it was really good because it keeps it simple. So here you see a regular LDL particle, and here you see a LP little a particle. So you can see that it comprises a LDL particle, but there's also this ApoA moiety that encircles it. Unfortunately, this ApoA moiety can be thought of as supercharging the LDL moiety because it makes it even more atherogenic. So it has effects on the rheostatic properties of blood, making the blood more likely to form clots. It has effects on the endothelium in particularly sensitive arteries such as the coronary artery to make it more likely that someone will develop plaque and also more likely that a plaque will rupture. Why do we care so much about LP little a? Endogenous elevation of LP little a is the most common genetic dyslipidemia. Enough so that in most countries in Europe, it's part of their preventative health guidelines that everyone gets a LP little a checked at least once in their life. LP little a does not really change in response to most of the common therapies that we use. So it's a very good marker that you can get to sort of establish an individual's risk of ASCVD, and maybe you might detect someone who has this common genetic dyslipidemia and be able to save them some pain in the future with early aggressive treatment. Importantly, elevated LP little a is also associated with calcific aortic stenosis. So this harkens back to the physical examination. Taking a listen at that aortic valve area is important. You might hear something. Recently, just in December of last year, there has been some update in the way that we use lipoprotein little a. From the UK Biobank analyses looking at almost 500,000 people, they've determined that there is a continuous log linear relationship between the level of LP little a and the risk of major adverse cardiovascular events. So this means that we're no longer looking at a dichotomy where LP little a is said to be low, okay, great. LP little a is said to be high, okay, bad. It's much more nuanced than that. So you really want to consider the degree of LP little elevation when you are determining what is the risk of an event in your patient. Now, what is apolipoprotein B? You may have noticed it on the prior slide. So we see apolipoprotein B. Where did it go? ApoB, right here in the core of the LDL. This is another little pictogram that I thought was really nice and simple and clear. So what we see is that there is a single ApoB for each particle of bad cholesterol. So there's a single particle of ApoB for each LDL moiety, for each VLDL moiety, and for each chylomicron as well. So this helps us to account for physical differences in the size and volume of LDL particles. Some people make big LDL particles like this, which are less likely to penetrate the subendothelial space. Other people make more small LDL particles, which are more likely to penetrate the subendothelial space and lead to atherogenic process. So persons who are at risk for producing a lot of these small, dense LDL particles are patients just like our patient. People with insulin resistance, people with diabetes, people with the metabolic syndrome, people with hypertriglyceridemia, and people who are obese. So a patient checks all of these boxes. It's a very useful test because of that one-to-one ratio with the total atherogenic particles I mentioned. This is a great test to obtain as a baseline because we can test it again. Unlike LP little a, this actually changes with treatment. And so it can help us know if a patient with all of these risk factors for elevated levels of small, dense LDL particles, if they're truly reaching their treatment target, even if their LDL-C appears to be normal. All right, so first question when we're assessing this patient, is this patient truly statin intolerant? In the literature, there's a term called the nocebo effect. The nocebo effect essentially tells us that patient's perception of statin intolerance might not be entirely physiological. It might be somewhat psychological. So in observational studies, up to 20% of patients are going to report statin-associated symptoms. Most commonly, these are going to be in the myopathic subgroup. So people are going to report muscle pain. However, in several very well-conducted randomized control trials, a maximum of 6% of patients report adverse statin-associated symptoms. So there's a huge difference between 20% and 6%. But does it really matter? It doesn't really matter, because if the patient thinks that they're having statin intolerance, they're not going to take the medication. So whether you show them that their CK is completely normal, they won't necessarily get the buy-in with you to, retry a statin or the same statin they were on before at the same dose. It's important because when people stop taking their statins, their risk of cardiovascular morbidity and mortality increases exponentially. We need to remember that this clinical problem is a spectrum, which means that, some people have slight pain, some people have a lot of pain, some people have true CK elevation. Those are people that we won't necessarily re-challenge with a statin. And you want to try to work with patients to identify their maximum tolerated statin dose. You want to use a statin such as rosuvastatin that has relatively low lipid solubility. It's less likely to penetrate the muscles and cause problems. And you can keep in mind that these tiny doses, so as low as 2.5 milligrams of rosuvastatin once per week, can lead to significant reductions in their lipid panel properties at 4 months. So this one study shows us that there was a 23% reduction in LDL-C on patients taking an average weekly dose of 10 milligrams. So 23% is quite significant. In addition, you still see some of the benefits for the reduction in triglycerides. You see a marginal increase in protective HDL. So if you take nothing else away from today, remember that if you can convince your statin intolerant patient to take a high-intensity statin that is low lipid solubility, such as rosuvastatin, for a tiny dose of 2.5 milligrams once per week, you are doing something to help them, and it's a good starting point. All right, so this is from the American Association of Clinical Endocrinologists, or ACE. They have a wonderful executive guideline that speaks to lipid management, as well as the strategies for managing statin intolerance and safety. You want to keep in mind when you're choosing a statin to prescribe for a patient, or you're deciding whether a patient will benefit from a statin, do they have risk factors for genuine statin-associated muscle symptoms or for genuine rhabdomyolysis? So some of these features are older age, female sex, if someone has a low BMI, if they are East Asian, history of prior muscle symptoms, impaired clearance for any reason, diabetes, HIV, certain medications. So we know that fibrates in combination with statins most likely will lead to true rhabdomyolysis. You want to keep in mind, again, the type of the statin. Simvastatin is notorious for causing SAS. If a person has low vitamin D, it's worth repleting it to see if that helps their symptoms. If they are hypothyroid, definitely correct their thyroid economy first. And if someone has acute infection, but we don't necessarily give statins in hospital, so we don't really think about that. So all of these things we spoke about. I do want to address a common question from patients, whether statins are going to cause them to become hyperglycemic or develop diabetes. So statins cause less than a 0.1% increase in individuals' A1C. So for the majority of individuals, let's say someone's A1C is 6.4, they're teetering on the edge of diabetes, but their LDL is 150 and they had a heart attack last week. It's going to be more helpful to the patient to start the statin than to be thinking about, the marginal chance of an increase in the A1C tipping them over to diabetes. Right, so the next question for our patient, now that we've established that it doesn't really matter if he's statin intolerant or not, we still need to absolutely figure out a good treatment plan for him. What is his risk stratification? This is another very helpful table from the same ACE guideline. This patient falls into the extreme risk category for a number of reasons. He has established clinical ASCVD and he has diabetes. Now, this criteria says plus diabetes or CKD3 or greater or heart failure. And he has all of the above. If he has a history of premature ASCVD, less than 55 years for a male, which he does have, or less than 65 years for a female, also extreme risk. So the treatment goals are going to be quite stringent. The treatment goal in this case is less than 55, the non-HDL treatment goal is going to be less than 80. And the ApoB we spoke of before is going to be less than 70. Triglycerides, we like to keep less than 150 across the board to reduce the risk of pancreatitis, but also in some studies to reduce the risk of cardiovascular disease. So here's everything together as a summary. The patient has obstructive coronary artery disease. He has uncontrolled mixed hyperlipidemia. It's likely polygenic. He's here in the clinic today for secondary prevention because he already had an MI, and it's all in the setting of statin intolerance. He's at extreme risk of recurrent MACE because of his diabetes, hypertension, stage 3 CKD, current smoking, and his personal plus a family history of premature ASCVD. So what's our plan going to be? First, we're going to establish our treatment targets. Then we're going to talk about what are the structured lifestyle changes we can recommend. We'll discuss the role for obesity treatment, and then what lipid-lowering medications we're going to use, and then how often are we going to recheck. So the table before summarized his targets very nicely. Again, that LDL-C of less than 55. Ideally, we'll get this on direct measurement because of his risk of metabolic syndrome, so because of the risk that the Friedewald equation is going to be incorrect for him. We'd prefer that. We're going to get the ApoB because of the risk that his LDL is going to appear to be normal, but he's a type of person that's prone to producing many small, highly atherogenic particles. And we want that ApoB to be less than 70. We want his HDL ideally to come up to more than 40, and his non-HDL to be less than 80. So here are our interventions. You can see that exercise can be expected to give as much as an 8% reduction in LDL. A 5 to 10% weight loss is pretty good. It's going to give us 15%. 2 diets have been validated for effective use in dyslipidemia, and that's the DASH diet and the Mediterranean diet. You can see you can get up to a 30% gain on those diets. For the medications, if you give him a low-intensity statin, we expect to see less than 30%. High-intensity statin, more than 50% reduction. And then we see the most powerful medication, which is what the patient came to clinic to get today. He wants a PCSK9 inhibitor because that's going to lead to as much of a 70% reduction in his LDL. There's a newer medication on the market called bempedoic acid. Seminal trial came out proving their endpoints in reducing MACE in the New England Journal of Medicine last year around January. So that medication acts upstream of statins by a unique mechanism, and it's not associated with statin myopathy or statin-associated symptoms at all. It's quite expensive. It's actually still the same price as a PCSK9 inhibitor because it's still under patent, but that can give you as much of a 25% reduction. And it's useful to remember this option, and it's available at the VA for people who are averse to injecting because the PCSK9 inhibitors, such as Repatha, are injectable medications. So for the changes, he has to stop smoking first and foremost. In terms of how much exercise does he need and what is the minimal amount that will be effective, as little as 150 minutes of strenuous exercise per week will be effective. There's data that it can be broken into 10-minute sessions and still be effective. We spoke about the DASH or Mediterranean diet. Patients are often more successful if there's a nutritionist touching base with them. For his obesity treatment, that's a little more nuanced. GLP-1 receptor agonists such as Ozempic, Mounjaro, we know are going to reduce triglycerides significantly independent of their effect on obesity. But we have to be careful in patients with severe uncontrolled hypertriglyceridemia who are at risk of pancreatitis because these agents can lead to increased risk for pancreatitis. He does qualify for referral for bariatric surgery assessment. Therapeutic options. It's worthwhile to encourage your patients to be rechallenged with a statin. The reason for this is that statins have what we call pleomorphic effects. They're going to improve the blood flow quality. They're going to improve the flexibility of red blood cells. So they independently reduce the risk of a blockage aside from their effect in lowering LDL. So you want to encourage him to take that once weekly rosuvastatin, 2.5 milligrams. Yes, we're going to give him the medication he asked for, the PCSK9 inhibitor, because of that 70% LDL lowering effect. So we can start with alirocumab, 150 milligrams subcutaneously once weekly. If he decides he doesn't want to take the injection for whatever reason, even though this medication is well tolerated, some patients may have a local rash at the site of infection, and that's really just about it. You can consider bempedoic acid because of the outcomes of that clear trial we mentioned before. What about his triglycerides? So remember that statins are going to reduce triglycerides by up to 35%. So if you take a third of 2,000, that's still going to leave us up above 1,000. So we're going to need more agents. Over-the-counter fish oil had some effect for this patient. It reduces triglycerides to the 400s in addition to the phenofibrate. But there is prescription-grade omega-3 fatty acids, such as icosapentae ethyl, which is known commercially as Vasipa. So this is the one preparation of purified omega-3 fatty acids that has displayed some clinical effect in reducing endpoint effects on the patient. So not just a lowering of the triglyceride numbers, but a reduction in primary and secondary ASCVD events when combined with a low-dose statin. When I should mention, I didn't mention before, this clear outcomes trial with the bempedoic acid, this was also in combination with a low-dose statin. So you do want to try to get them to take a statin as much as possible, even if you're letting other medications do the heavy lifting. For his diabetes, we can actually refine his medication and add pioglitazone. Pioglitazone is not commonly used, but it's quite a good medication for people with concomitant hypertriglyceridemia. It can lead to a 15% reduction in triglycerides. So if you add all those percentage points up together, we're going to get some reduction. The PCSK9I that we are prescribing this patient can also be expected to give up to 30% reduction in triglycerides. With the pioglitazone, we need to be careful if we decide to rechallenge with phenofibrate, because it can increase the bioavailability of phenofibrate, and that can lead to myopathy or muscle pain. So that's going to be a less favored option. One of my mentors, Dr. Guyton, he's a huge fan of niacin. The lipid community right now does not necessarily endorse the use of niacin for many reasons. The data is not very robust that it works very well for most patients, and part of that might be in the real world, it's hard to comply with. With his CKD, we would not prescribe him NSAID to take to reduce the flushing with every single dose. That's not going to be safe for him. So it's not the best bet. If you were to use this medication in this patient, you could tell them to take extended release preparation and to take it at bedtime to mitigate the perception of flushing that's quite uncomfortable for patients. So how often should lipids be checked? Right, and I'm almost finished, don't worry. I'm gonna speak very fast. So according to the guidelines, they should really be checked 6 weeks after revised therapy. In reality, we know that we're not gonna be able to see our patients less quickly. So therefore, you can think about doing 3 to 6 monthly. Once the therapeutic regimen is stable and the patient has met their goals that we mentioned before, you only have to test once a year. If there's a change in their clinical status, so if their renal disease gets worse, they develop diabetes for the first time, they have an MI and their targets change for whatever reason, then you're going to retest the lipids more frequently. Right, so these are some resources. At the top there is a guideline from ACE that I mentioned. I want to say thank you to Dr. Guyton, Anna Schaefer, our NP at Duke, and Dr. Bernal Mizrahi, who reviewed my presentation for me.
Thank you, Dr. D'Souza. That was an excellent didactic lecture and appreciate all the review. You did it well. We're proud to see you back here. Just a quick question before we go into the next speaker. Why did you choose pioglitazone as opposed to a GLP-1 agonist, given the anti-obesity, anti-diabetes, and anti-lipid effect that it would have compared to pioglitazone?
So in this particular patient, the biggest reason was that we wanted to lower his triglycerides first. If we saw a number that was closer to 500, we would have been more comfortable prescribing the GLP-1. The fear was the risk of pancreatitis. That's said to be additive with the hypertriglyceridemia and the GLP-1.
Is there data?
No. Excellent question. This is going to be, what do you call it? Anecdotal. So experiential data. Yes. No problem. Thank you.
Now, please join me to introduce Dr. Quesada. She's a physician scientist with a distinguished career in autoimmune disease research. She earned her medical degree at the University of Barcelona and completed her rheumatology residency and pediatric rheumatology training at Valdebrón University Hospital in Spain. She further specialized with a fellowship at the Istituto Gianna Gaslini in Italy. She obtained her PhD with highest honor at the Autonomous University of Barcelona, focusing on immunological differences in juvenile idiopathic arthritis. She continued her research at La Jolla Institute for Immunology, where she made significant contribution to understanding immune mechanism of type 1 diabetes, including demonstrating beta cell HLA class II upregulation in response to inflammation. Now at the University of Miami, she holds an R01 grant and investigates autoimmune disease pathogenesis with a focus on childhood onset conditions like type 1 diabetes and juvenile idiopathic arthritis. Recognized with multiple awards, including the 2023 the Network of Pancreatic Organ Donor with Diabetes Young Investigation of the Year, she continues to advance the field with her multidisciplinary expertise. Please join me in welcoming Dr. Quesada.
Hi, welcome everybody. Thank you for the introduction. I'm a adult and pediatric rheumatologist who is doing research in type 1 diabetes for the last 7 years. And with this presentation, I hope that I can convince you that my background in rheumatology is actually adding value to my research in type 1 diabetes, and that my research in type 1 diabetes is also adding value to my research in arthritis. So today I'm going to have a background about juvenile idiopathic arthritis and type 1 diabetes, that are the two diseases that are close to my heart, and also they are close sometimes for clinical association in the families and in the patients. They share some common pathways that I will explain about, and then I will very briefly explain how with my research I've been reaching some of the gaps in between different autoimmune diseases. So the clinical case is of a 16-year-old girl who has been diagnosed with type 1 diabetes and dealing with the disease for the last 11 years, who is admitted to the rheumatology clinic for 2 months of chronic pain and swelling in multiple joints, in both knees, both ankles, both hips, shoulders, temporomandibular joint, and who does not respond to non-steroid steroid anti-inflammatory drugs. In the ultrasound examination, there were signs of synovitis, and there are in the laboratory findings, what stand out was an increased acute phase reactance with the presence of positive rheumatoid factor and positive anti-citrullinated antibodies. And this patient was also diagnosed with polyarticular rheumatoid factor positive juvenile idiopathic arthritis according to the ELAR criteria. This patient initially was treated with methotrexate, which is an immunomodulatory drug, and then sulfasalazine was added, and due to poor response, she was switched to anti-TNF therapy with good response, but before she was able to respond, she needed glucocorticosteroid therapy to bridge in between flares. And because of this glucocorticosteroid therapy, she had a deteriorated metabolic control that required more closely monitoring from the endocrinologist team. And this patient is just to give you an example that different autoimmune diseases can coexist in these patients. These patients made it into adulthood. This child is now 16-year-old, but she will still be living with both of those diseases when she's in her 20s or in her 30s. So these patients actually arrive to the clinic, and I'm going to show here first some background about these two diseases and then explain how these diseases can coexist in both the patient and the family. Juvenile idiopathic arthritis is a rare disease, but this is still the most common chronic rheumatic disease in childhood. Actually, this term is an umbrella term because it considers 7 different subtypes, and as a disease is very heterogeneous. We have the systemic subtype that is more similar to the Still disease in the adult. Most of these subtypes, they have their adult counterparts. And sometimes they even get reclassified or re-diagnosed when they make it into adulthood. Sometimes it's just for the sake of having an easier handling of the drug medications with the insurance companies. But basically, patients who are like this child, rheumatoid factor positive, polyarticular juvenile idiopathic arthritis, they are going to have a clinical course similar to the seropositive rheumatoid arthritis patients. And even though they share many similarities clinically, and some of them they have their adult counterpart, they also have some peculiarities that are more specific of juvenile idiopathic arthritis. And uveitis is one of them. It can affect up to 20% of the patients, and it has some differences with the typical uveitis that we can see in an adult patient. In kids, this uveitis is typically chronic and asymptomatic, and these patients require very standardized and close ophthalmologic control in order to not lose a potential flare in the eye, because it's still nowadays a cause of blindness in the Western world. And type 1 diabetes is an organ-specific, also autoimmune disease that affects the beta cells located in the endocrine region in the pancreas. Those are the insulin-secreting cells. And its incidence is actually increasing quite relevantly in the last few years, and we have not really figured out the causes for that. When I started studying type 1 diabetes 7 years ago, we had 187,000 children and adolescents in America, and in America affected by the disease. And nowadays, this is the last number that the CDC gave us in 2021. So it's a significant increase. And it's not the only autoimmune disease which numbers are going higher up in the last few years. And as an autoimmune disease, it has very specific peculiarities when we compare with the animal models and what we observe in the animal models. And actually, we don't have a perfectly great animal model for this disease. For instance, in humans, we have the pre-diabetic stage where we can detect autoantibodies in the patients. And actually, there are several reports out there that mention that the higher the number of autoantibodies, the higher is the risk of this patient of developing type 1 diabetes in the next 5, 10, 20 years, especially if they have genetic risk already determined. And this pre-diabetic stage can last literally for 20 years, where we can detect some of these autoantibodies, but maybe the patient still has enough beta cell mass. The loss is like very, very slow at that time. And then once an abnormal oral glucose tolerance test is detected, then this loss tends to be a little bit more abrupt, and then we are closer to the moment of diagnosis. But even after diagnosis, in type 1 diabetes, we have this honeymoon phase where many patients can be still free of insulin for many months before they become insulin dependent. And we have several opportunities to preserve the beta cell mass in order to keep the patient insulin free if we really find a way to reverse or to stop the mechanisms inducing the disease after these autoantibodies are detected, or even in the moment of diagnosis to extend this honeymoon phase. So this beta cell loss and function is highly variable between individuals. Sometimes we stain the tissues of patients who have been diagnosed with the disease for 10 years, and they still have insulin-producing beta cells in their pancreas. They, of course, have a severe loss, but you still can see it. It's just that they don't produce enough to compensate for the needs of their bodies. The degree of immune infiltration is much lower than what we observe. Typically, for instance, in the NOD mice, we have hundreds, thousands of immune cells going to the islet, attacking and destroy them very fast. And these are like very abrupt, like preclinical type of autoimmune diabetes. But in the clinical human diabetes, the onset is more insidious, and there is a lower degree of infiltration. Sometimes we have 2, 30, 100 cells infiltrating the islet, and many immune cells have been associated with the disease, like antigen-specific CD8 T cell, macrophages. The exocrine pancreas is involved in the disease. Every time we study one immune cell, we see also an increased infiltration in the exocrine regions, even though those patients don't have clinic of having an exocrine malfunction. And what is very interesting is that there are these studies where they did imaging of the pancreas, and they observed smaller pancreas size, not just in the patient, but also in the first degree relative of those patients who are not affected by the disease. One of the hallmarks of the disease in the tissue is hyperexpression of HLA class 1 and hyperexpression of HLA class 2. Whether beta cells were able to express HLA class 2 was a highly controversial topic for for like 20 years. And I would say, I think that now we are at the point where we can say that it's confirmed that under stress and in type 1 diabetes, a proportion of these beta cells that can be something between 20-30% of them can express HLA class 2. And this is one of the studies that also did. I'm not going to talk about this study today, but it's the one that actually made me evolve a lot about the technologies that I was using to study the pancreas. So how often are autoimmune diseases associated in the same patient? Actually, more often than what we could expect by random statistical association. This is a study done in Sardinia, in the population of Sardinia, and the data is coming from general practitioners in the island and included more than 25,000 patients, and you can see how the number of expected patients who were gonna being affected by more than one autoimmune disease was much lower than the number that was observed. And this was true for both women and men. And actually, if we specifically see how often is the presence of another autoimmune disease in patients with type 1 diabetes, is actually more prevalent than what we would be expecting because of what we see in the general population. Actually, overall, we are seeing 23% of the patients approximately with type 1 diabetes coexisting with another autoimmune disease, while in the general population, we have something between 4, 9, 10%, depending on the population of the people affected by autoimmune diseases. And we can see how this risk is increased for rheumatoid arthritis, for juvenile idiopathic arthritis. For psoriasis, it's a little bit controversial. It depends on the actually cohort that you are seeing, but most of the studies seem to point out that there may be an association, not as clear as it is for rheumatoid arthritis or lupus or juvenile idiopathic arthritis, and of course for thyroid disease, that is the most prevalent one. And how often is the family association in those patients? So actually, also more often than what we could expect in general. So if you have a patient with type 1 diabetes, there is an increased risk of all of these autoimmune diseases in first-degree relatives of that patient, including multiple sclerosis, psoriasis, lupus. And I included the data for juvenile idiopathic arthritis from another cohort. Actually, these dots that you can see come from a meta-analysis where they actually checked more than 2,000 papers, but they end up including 44. And the data coming from juvenile idiopathic arthritis is from actually a Finnish cohort of 355 families, where they observed that when there was a patient with juvenile idiopathic arthritis, there was a higher risk of juvenile idiopathic arthritis, rheumatoid arthritis, psoriatic arthritis, multiple sclerosis, celiac disease, and type 1 diabetes in the extended family. And actually, there are other studies that they have checked that when the parent and one of the siblings is affected by the disease, the risk of having more cases in the family multiplies exponentially. And instead of doubling, it's like 5 times higher. So there is this significant association, and the reason for this family clustering, it's probably a combination of both genetic and environmental factors. And which are the common pathways that this autoimmune disease share? So today, nowadays, it's still widely accepted that an autoimmune disease typically occurs in an individual where there is a genetic predisposition, where something happens in the environment that breaks down the tolerance of the body to keep tolerating our own antigens while still fighting the antigens that are coming from the outside wall. And this is true for most of the polygenic autoimmune diseases, because monogenic autoimmune diseases are another story mostly. But for a polygenic autoimmune disease like type 1 diabetes or typically rheumatoid arthritis, that's what we have accepted as the situation nowadays. And we can see how these, for instance, musculoskeletal immune-mediated inflammatory diseases share some genetic mechanism. This is a diagram where you can see how juvenile idiopathic arthritis is sharing genetic traits with psoriatic arthritis, with systemic lupus erythematosus, with rheumatoid arthritis. And in the specific case of type 1 diabetes, it's believed nowadays that 50% of the risk for the disease is coming from the region in the chromosome 6 that is encoding for HLA genes. But there are many other genes that are connected to the risk of the disease that actually impact T cell in terms of their function, in terms of their development, their activity to regulate and to create inflammatory responses, as you can see here in the graph. And actually, many of these genes are common shared genetic risk mechanisms with juvenile idiopathic arthritis and also with rheumatoid arthritis. And it's not just for the HLA class 2 or the genes connected to the HLA region, but also to the genes, for instance, connected to cytokines or to PTPN22 and to CTLA4. And I'm going to talk a little bit about IL-6 and IL-17 because there are several polymorphisms that have been described that may be playing a role in the risk of developing juvenile idiopathic arthritis, rheumatoid arthritis, and type 1 diabetes. And some of these data is clearer than others, and some of the polymorphisms are more controversial than others. But because these two cytokines have a therapy, for instance, we have tocilizumab, that is a humanized monoclonal anti-IL-6 receptor antibody, and we have secukinumab, that is an anti-IL-17A antibody, I think are two interesting cytokines to mention a bit about their pathways. So for tocilizumab, we know that it's a pleiotropic cytokine that is involved in both innate and adaptive immune responses. And the fact that it's pleiotropic is important because we typically consider it a pro-inflammatory cytokine, but depending on the situation, it can be actually having anti-inflammatory properties. We have high levels of IL-6 in patients with juvenile idiopathic arthritis and rheumatoid arthritis have been described, and also in connection to obesity, insulin resistance, and type 2 diabetes. And actually, it is approved as a therapy for both rheumatoid arthritis and juvenile idiopathic arthritis, the polyarticular subtype. But we can also see an increase after exercise. It's just that typically this increase is like more limited in time instead of being more chronic. In type 1 diabetes, instead, the reports are more conflicting. And whether there was an increased level in the plasma, it has not been that clearly determined. And it has been more clearly determined that it seems to be an increased secretion by the monocytes in recent onset patients. It seems to be a more sensitivity of CD4 and CD8 T cells to the IL-6 pathway, and that blocking the IL-6 pathway in patients who had diabetes and rheumatoid arthritis seemed to improve the A1C levels. But the evidence was pretty limited to just, I think there was one study that, for instance, just 10 of the patients were really having this improvement. So the number of patients where this improvement was observed was limited. Anyway, regardless, there was a clinical trial that was conducted in recent onset patients with type 1 diabetes where tocilizumab was not effective at treating the patients at keeping the beta cell function or at slowing the loss of beta cell rate. And there are several reasons for that. For instance, there were two previous papers where they observed that IL-6 in vitro had some protective mechanisms preventing autophagy after those islets, those beta cells in this case, were stimulated with other pro-inflammatory cytokines, or reducing the oxidative stress on the islets that were receiving inflammatory stress. And also, personally, I work in a study where we systematically quantified in the pancreas the expression of IL-6. And here you can see one islet of a non-diabetic donor. In green, you see the insulin. In blue, you see the glucagon. And then in red, you see the IL-6 signal. And look how the non-diabetic, the pre-diabetic are having high IL-6 levels that seem to be lower in the insulin-containing islets of the type 1 diabetic patient, clearly much lower in the insulin-deficient islets of the type 1 diabetic patients, and also lower in the islets of the type 2 diabetic patients. And this was quantified, and we observed that it seemed to be the case, and that this main source of this IL-6 seems to be mostly the beta cells. And that IL-6 receptor was actually also present in these alpha and beta cells. This means that probably IL-6 has some function in the homeostasis of locally in the pancreas, and it's a cytokine that is, if it's there in the healthy controls, then it's there to keep the cell like normally functioning. So even though the effect of anti-IL-6 therapy can be beneficial for the effect that it's going to be doing in the T cells, maybe it's not going to be as beneficial in what it's going to be doing locally in the pancreas. And for secukinumab, we typically think it's a pro-inflammatory cytokine. It's more typically a pro-inflammatory cytokine. And there has been described increased concentrations of IL-17, again, in both the serum and the synovial tissue of patients with different forms of arthritis, in this case more commonly in psoriatic arthritis, but also there are reports in rheumatoid arthritis. And it's approved and effective to treat psoriasis, psoriatic arthritis, and the psoriatic and an enthesitis-related form of juvenile idiopathic arthritis. And in type 1 diabetes, again, the role was unclear because these accentuated anti-apoptotic effects of the of IL-17 have been described in vitro in islets receiving also pro-inflammatory cytokines. So with IL-6, there was certain protection, but with IL-17, it seemed to me to make the apoptosis worse. There were increased levels of IL-17 in Th17 cells in the peripheral blood of patients with recent onset type 1 diabetes, and one study reported an increased expression of IL-17 in purified islets of a patient with type 1 diabetes when compared with the non-diabetic islets. But there was a phase 2 clinical trial that was terminated actually in 2016. The results were not published, where apparently there was not really benefit in this very limited number of patients with the drug. And we also quantified in the tissue how much IL-17 was present in the pancreas of patients with type 1 diabetes and in the normal controls and in patients with type 2. And here we still see insulin in green and glucagon in blue, and IL-17 this time is again in red. And you can see how in this case, non-diabetic and pre-diabetic seem to have lower levels than what we can observe in the insulin-containing islets of the patient with type 1 diabetes and in the islet of a patient with type 2 diabetes. And in this case, a little bit to our surprise, actually the levels in the patient with type 2 diabetes were higher, and they were higher specifically also in the beta cells. And here you can see one magnification of an islet, where here in green you see the beta cells of a patient with type 2 diabetes, in red the IL-17, and how IL-17 is being expressed by both the beta cell and the alpha cell glucagon positive. And then for the non-diabetic individual, you can see how there is virtually no expression of IL-17 in the beta cells, and there is some expression in this alpha cell, but I purposely chosen this image. You don't see it in many of the images, just to show that even when it's present, it's very puntiform and much lower than what we see in the type 2 diabetic or the type 1 diabetic individual. The reason why we were actually expecting to see more IL-17 in type 1 diabetes and in type 2, but it also makes sense because type 2 diabetic individuals typically are more overweight, have more fatty tissue. There is a source of IL-17 that can come from this fatty tissue, and it can be part of the mechanisms also of this low degree inflammation in type 2 diabetes. And I have shown you how I have done these studies with the tissue with the pancreatic tissue of human donors. And these studies actually were using what I call traditional methods. So I was staining for 3-4 proteins at a time. I was selecting 30 antibodies, 30 regions of interest, in this case islets, that in principle was reproducible. We had internal data saying that if you analyze all these 30 islets, you were getting reproducible results, but it was very difficult to grasp subtle changes and what was going on with whoever was a little bit more in the edges of the spectrum, because in a pancreatic tissue of a healthy donor, you have something between 300 and 1,000 islets. So if you choose 30, you are actually losing most of the information. And also, I mentioned that I was staining for 3 colors. So nowadays, here at the DRI, we have at in the DRI, we have one technology available where we can stain in just one shot 16 to 18 antibodies and do the immunofluorescence acquisition, do spectral extraction, and then because this technology is very gentle with the tissue, we can do H&E posteriorly and correlate some of the findings in H&E with the findings of immunofluorescence. And this technology was initially developed for cancer. Actually, when we study tissue, most of the times we are after cancer. Many things that have been developed for cancer that have been first tried in cancer, then you can apply them to study the pancreatic tissue, or you can apply them to study other tissues. And here this is an image of a tonsil human tissue using this panel with, this is a panel very heavily in immune cells, in CD4, CD8, CD20, and CD45 a row. And this is the comparison with the traditional immunofluorescence methods with this new technology, and a detail without the nuclei just to visualize the infiltration of CD4 T cells with CD8 T cells. This is a heavily infiltrated islet for being human of CD45 cells, macrophages. And what I did for the HLA, for the paper where we analyzed the expression of HLA class 2 was to develop a pipeline based on machine learning, both supervised and unsupervised analysis, to basically take the information from the whole tissue. So instead of analyzing 30 islets, I'm analyzing as many islets as the tissue has. I train a classifier to identify my regions of interest, and then I can create, for instance, the peri-islet regions. I can do cell detection, cell classification, not just in the regions of interest, but also in the whole tissue. And here you can see some detail of cell detection and cell classification in the islet. And what is interesting, it's like then I can feed all the raw data without any supervision, training, nothing, into a second software that can automatically, in this case is with no training, tell me which are the clusters, where they are located. And here you can see, again, human tonsil tissue, and you can see how the microanatomy of the germinal centers is being determined by the system, not by myself, just because the populations, the immune populations composing the tissue were different. So while this technology, sorry, because the quality of the image is not great, but it's, incompatibilities with Mac and other systems. But basically I was able to transfer all this pipeline to study also synovial tissue. And I can also do cell detection, cell classification, and I can also use this new technology of 18 markers in the synovial tissue. And we have a small study actually going on, which preliminary results have been accepted in EULAR this year. I have just been notified. And in conclusion, I hope that I convinced you after the talk that there is some association with autoimmune diseases in the same patient and some aggregation in the family. And this is relevant for clinical practice because if you see a patient already affected by a autoimmune disease who is experiencing some symptoms compatible with another, maybe consider that this is a higher probability than for other patients without this background. Some autoimmune diseases like type 1 diabetes or juvenile idiopathic arthritis share some common genetic risk factors. And even though we understand some of these factors, we still don't fully, completely reverse or treat all the patients. And lessons learned for one disease can help to treat another autoimmune disease, even though unfortunately it's not always the case, as I have shown you today about tocilizumab and secukinumab. And research is transversal, so every time we advance new technology, new methods, and we learn something in one disease, we can potentially know more and learn more from another disease. And thank you very much all for your attention.
Thank you, Dr. Quesada. That was a very important presentation that we often don't think about in the transition of patients from pediatrics to adulthood and the ability to be able to recognize other autoimmune conditions as they occur. I want to thank both our speakers today for excellent grand rounds. I want to remind everybody to check the QR code at the exit, as well as check the link in the chat for your CME and MOC. I look forward to seeing everybody next week. And for the residents, we have resident report, I guess, next door. Is that right? Or we're staying here? We're going to Central 2 for Jackson for resident report. Okay, everybody, thank you so much.